Hi everyone. Sorry, we'll try to keep it short. I know everybody is tired. अभी काम किया है. So okay. So drug elution, you've heard almost 1.5 days. So this is basically used to prevent and treat arterial restenosis. And we've seen that two drugs or two group of drugs. One is your rapamycin, Sirolimus, and Paclitaxel, and you've all gone through this. There's just one. Last two lines are the important ones, which I felt which have not been covered. So the anti-proliferative effect is more on the hypoxic atherosclerotic cell, which is more seen with Sirolimus rather than with Paclitaxel. And that's one of the reasons why sometimes you're seeing that the Sirolimus is giving better responses. Another important thing is drug-eluting stents with Sirolimus continue to be used, but with Paclitaxel have not been used because of safety concerns. Now what happens with this is that here you can see a picture of how the drug, once you put it inside the body with the balloon or the stent, there's dissolution, then there's absorption, and you can see that the active drug starts getting into the walls of the artery, and the distribution varies whether it is Sirolimus or whether it is Paclitaxel. So what is important is how does this work? So it's inhibition of new intimal formation, but the side effect is that it also inhibits re-endothelialization, as we talked about, inhibition of EPC, homing and proliferation, and induction of tissue factor, which causes thrombosis. So risk of thrombosis starts with immediate use, so it's early. It can be late, it can be even very late. So there are people who have stopped using anticoagulation, adequate anticoagulation for say 1 year, and they have ended up with thrombosis, mainly because of these reasons. So what are the factors which promote thrombosis? So it's delayed re-endothelialization and healing of intima. So this causes exposure of intimal defects post-angioplasty. It causes exposure of the stent, and more important, the polymer to the blood flow. Tissue factor expression, that's inhibition of mTOR and activation of JNK. This is a picture which shows Paclitaxel stimulates JNK, which is important because that stimulates tissue factor, and rapamycin inhibits mTOR, which is important for inhibition of tissue factor, but because that gets suppressed, what happens is the surface tissue factors get exposed and the clot formation is there. So procedure related factors, high pressure barotoma, so we discussed that yesterday, that using low pressure sustained is giving better results than using high pressure. Improper apposition of stent to the arterial wall, that is also important. Many a times we find that we don't have the stent we want and we use whatever is available, and that itself can create more problems. So availability becomes an issue, may not be so much in big centers, but in smaller centers where there is an issue of availability, that becomes an issue. Hypersensitivity reaction to polymers used to hold and deliver the drug. Inadequate anticoagulation. So this could be because of resistance to antiplatelet drugs, especially the CYP2 C19 allele, which is very important for resistance for clopidogrel. Delayed starting or premature discontinuation of anticoagulation and antiplatelets. This itself can cause issue. And then we have this thing whether we use a dual platelet inhibition or use a double antiplatelet therapy. And there are patient-related factors which include low ejection fraction, diabetes, advancing age, and thrombotic occlusion. So when you have occlusions which are thrombotic and we use this technology, the thrombus there itself can cause stimulation and further thrombosis. So this is a picture, I'll show you a couple of these, primary to push home the factor that here you can see that there are two issues here. One is the platelet factor, which is important, and the stimulation of the intrinsic and extrinsic pathway. Similarly, here if you see the platelet, there are three issues that take place. One is adhesion of the platelets, second is activation of the platelets, and third is aggregation of platelets. Right? So in addition of platelets, you have aspirin, which is an important part, which is a COX-1 inhibitor, which blocks the thromboxane inhibitor, and as a result of that, it reduces the adhesion. Also, it reduces the activation of the platelets. So here, PAR1 antagonists like rivaroxaban is an important factor. You have the ADP P2Y12 receptor antagonists, which includes your clopidogrel, prasugrel, ticagrelol, ticlopidine. You also have the 5-HT2A antagonist, which is naftidofural. So this is used, there were studies for using prevention of restenosis and improving claudication. And you have the aggregation inhibitors, which is the GP1A2A inhibitors or GP2B2A inhibitors like your apixaban and monoclonal antibodies. So this is gives you a more detailed, easily readable format, which tells you the thromboxane inhibitors is the aspirin, the PAS inhibitors is the Vorapaxar, rivaroxaban, the ADP receptor antagonists, which includes the clopidogrel, the prasugrel, the ticagrelol, the ticlopidine, and the G2P3A inhibitors, which is the apixaban. Okay, so this looks a little complicated slide, but it's important for two reasons. One is it also tells you what is the role, besides antiplatelet, what is the role or involvement of the antithrombin. So we all know about the aspirin and the COX-1 inhibitor. We know about the P2Y12, dipyrimidol. Everybody remembers this drug? Persantin. This was also used and very popular at some. So there are lots of drugs which we are not using, which may have a role, especially if you have a situation where the existing drugs are not working. Silestazol. Silestazol is a phosphodiesterase 3 inhibitor, and that also has an antiplatelet factor. You have the PARS inhibitors, which is the rivaroxaban and the vorapaxar. And don't forget the apixaban. And last but not the least is the thrombin inhibitors. So whether it's unfractionated heparin, low molecular weight heparin, whether it's dabigatran. So if you look at this, this gives you an idea of comparison of various antiplatelet drugs that are available for us. One is aspirin, acetyl salicylic acid, COX-1 inhibitor to thromboxane X2. It plays an important role for prevention of adhesion, activation, aggregation, as well as thrombus, because it acts at the fibrin level and stimulates or rather blocks the formation of thrombus. Clopidogrel, which is a thienopyridine, so it's a P2Y12 ADP inhibitor, and it's mainly involved in prevention of activation and aggregation. Prasugrel is a thiopyridine prodrug, and that also acts at activation or aggregation. Ticlopidine, nobody uses it now primarily because of the risk of agranulocytosis. Ticagrelol, which is a cyclopentyl triazolopyrimidine, again that's an ADP inhibitor, and that also acts similar to your clopidogrel, prasugrel. Silestazol mainly acts at prevention of aggregation, which is a PDE3 phosphodiesterase 3 inhibitor, and rivaroxaban, which is a monocarboxylic acid amide, which blocks the PARS4 and PARS1 inhibitor and prevents activation as well as prevents thrombus formation. So what is the evidence for antiplatelet post-revascularization? Not necessarily related to drug eluting, but any procedure that we do. So PAD antithrombotic practice patterns vary widely. DAPT after endovascular intervention is the norm, but one is not really sure how effective it is, but that is standard practice. And there is a lot of reluctance to move away from the standard practice. Little data to support varying DAPT prescribing patterns, which are generally influenced by coronary artery disease treatment patterns. There is no positive data published in the PAD revascularization setting since antithrombotic trialist collaboration in 1994. That's almost 30 years ago. So what are the DAPT recommendations after PAD interventions? So you have different bodies. You have the ACC AHA guideline, which says that DAPT may be reasonable to reduce the risk of limb-related events after lower extremity revascularization. You have the ESC, which is DAPT is recommended for 1 month after intervention. CHEST gives a guideline which says single antiplatelet, recommend against DAPT. Silver PTX, they use DAPT only for 2 months. Impact SFA, DAPT for 1 month without stent, 3 months with stent. Now coronaries they use for a longer period. So therefore these kind of guidelines can create more problems for us, and as a result of that we have to really think about whether we can follow it. So despite lack of robust evidence, patients are often treated with DAPT following peripheral revascularization. And here you can see that you have patients with only with an oral anticoagulant, no P2Y2 inhibitor, P2Y inhibitor before or after procedure, P2Y2L inhibitor less than 30 days after procedure, more than 30 days after procedure. So what is also important here to understand that there is what is the incidence of clopidogrel resistance. It can be 8 to 44%. But that's pretty high. So that means if you are going to be relying on aspirin and clopidogrel, and especially using a drug-eluting some technology, one doesn't really know whether your anticoagulation or antiplatelet is going to be effective or not. And that's a big ask after you have done all this procedure. Prasugrel resistance is less than 11.5%, so less than 10%. Ticagrelol resistance is very rare, and that's one of the reasons why the cardiologists tend to use either Brilinta or Prasugrel when they are doing all these procedures, and most of the times they are using drug-eluting stents. So let's look at this slide again, which I had showed first. So is there any combination that works at both levels? So what are the two levels? So one is the platelet level, and second is the thrombin level. So if you have something which acts at both levels, then it will be beneficial for our patients. So what is this combination? We all know this slide, especially this came up when we were talking about the COMPASS and the Voyager study. And here you can see that your aspirin, low dose aspirin, acts at the COX-1 inhibitor level, and the rivaroxaban low dose again acts at two levels, the platelet level as well as the fibrin level. And that's how you can see to it that you get better protection. So DPI is dual pathway inhibition, and that's supposed to be work. So what are the protocols that are used? So one option is you use, this is mainly for coronaries. Sorry, this is for so we'll compare with both ischemic heart disease as well as PAD. So DAPT of aspirin with clopidogrel. So generally the cardiologists tend to preload before they are doing any of these procedures so that you have that protection. Primarily because they are using, most of them are only using drug-eluting stents. So preloading is an important part, and generally most of them will continue ISD for a longer period, dual platelets. Post-op, in PAD, we usually started post-op, and we can give it for 3 to 6 months. Some people discontinue the second antiplatelet much earlier and then stick to only antiplatelet. Prasugrel and ticagrelol is used extensively by the cardiologists, but we don't have any data of using it for peripheral arterial disease. DPI, again there is a reluctance from the cardiology side to use these molecules. Whereas because of Voyager, we find that these are patients who have already been on DPI, or you start them post-operatively as early as you can. And generally the idea is to continue for lifelong. What about three drugs? Aspirin, clopidogrel and rivaroxaban. Again, you don't have any cardiology data for that. Many times what we are doing is vascular surgeons tend to use this post-operatively. At least start rivaroxaban maybe a few days later when they feel that it is safe. So what about when you are using it for DCB or DES? So again, same thing. We are not really sure what the data is, but what we can use is decide is based on what we have seen. So what about role of clopidogrel as a third agent post-revascularization? the efficacy and safety of rivaroxaban plus aspirin versus aspirin alone is consistent regardless of background clopidogrel. So here you can see that the primary outcomes, efficacy outcomes are good. Safety outcomes are also good. Patients more likely to receive clopidogrel in the Voyager study were the Caucasians, ladies, hypertensives, diabetics, hyperlipidemia, CAD with prior intervention or CABG, prior peripheral intervention. All these patients were already on clopidogrel and therefore there was a reluctance to stop it. Addition of clopidogrel as a third agent is associated with a higher rate of bleeding during exposure, especially if it is used for more than 30 days. In the absence of a clear benefit, clopidogrel exposure along with aspirin and rivaroxaban should be minimized or avoided to reduce this risk. So, the subgroup analysis of the clopidogrel in the Voyager study, the objective was to determine if efficacy and safety of rivaroxaban were consistent regardless of background of clopidogrel use, and to explore the temporal patterns of bleeding in relation to exposure and duration of clopidogrel. So here you can see the clopidogrel use at randomization, 50%, aspirin again, so it was well matched, no difference in p-value. You can see that there is difference in the duration of use. Most of them were used for 30 days or so. Median duration for drug-coated products which was given is for at least 31%. Here you can see aspirin was 32. So again, not statistically significant. So really speaking, we don't really have an answer. But what you can see here, that when you have clopidogrel added up, the risk of bleeding starts going up after 30 days. And that's one of the reasons why you try to reduce your triple dose to less than 30 days if possible. So, unfortunately, there is no real data, and one really wonders what should be done. So, you follow the cardiology protocol, or we follow scientific rationale, where there is some scientific basis based on which we can use, play safe and continue the same, or develop our own evidence, and which is where the registry will make a big difference and decide what you want to do. So, all of you must have seen the slide before. It's my favorite slide. It's always important to aim high but play safe. Thank you.